Good afternoon, everybody. Like Jason, when he did this survey, a lot of my initial slides are going to be redundant, but Doc Tom said redundancy was okay. So I will move through those fairly quickly and talk about sort of not just the context of where PPQC started, but where we are now in the process and where we hope to go in the future. And I joked, for those that were at the Wednesday session, I joked that I am not a clinician, even though I do work with doctors very closely and talk to them all day, every day. But when EJEF threw that slide up, I mean, that looks like science fiction to me. So that was literally the Matrix, while some of you are looking at probably understanding. So I don't know, again, how I'm at an IT quality forum. But I'm happy to be here and appreciate MiHIN. I've learned a lot over these last 3 days. So as Rick mentioned, going to run through the Physician Payer Quality Collaborative initiative. This is an initiative that started from the Executive Council of Physician Organizations. We have 12 partner organizations, represent more than 7,000 physicians across the Lower Peninsula. Many of these groups, while they do have employed physicians as part of their network and are affiliated or aligned with major health systems or hospitals in the state, largely independent private practice doctors. The mission of the Executive Council is to support the leaders of those organizations as they support their practices in clinical transformation and help them achieve what we're now calling the quadruple aim: higher quality, lower cost, and a better clinical experience for both the patient and the physician alike. So I guess we're making a stool now, or a chair now, what used to be a three-legged stool. When we started this group in late 2014, we conducted a strategic planning survey. I think we teased out about 40 different items. The top priorities from that survey were quality measure alignment and HIE infrastructure design. In further pursuit of how we tackle those priorities, we asked physician organization leaders to submit an open-ended survey on quality measures that they would like to prioritize. We got about 35 to 45 common outcomes across that survey. In attempting to tackle the issue about HIE design, we had invited Tim Pletcher, who's the executive director of MiHIN, to a meeting in March of 2015, just to talk about what does the HIE infrastructure look like in the state of Michigan, and what are the current activities. And in his presentation, he had talked about a number of areas where he felt physician leadership could help improve the process and move things along a little bit more rapidly. One of those areas was quality reporting, which tied in nicely to the first priority, and that was sort of the end of that March meeting, was sort of the early formation of the PPQC effort. So in June, following that March meeting, June of 2015, we went to the major health plans in the state, and we expressed our desire to have a discussion around quality measurement alignment. We made the same ask of the health plans to submit an open-ended survey of quality measures that they would prioritize for alignment. Across all those data sets between the PO Council and the health plans, we had 9 common measures across everyone, and then we had an additional 15 that resulted in 24 common measures. And we ended up adding 3 more based on feedback from CMS and people that work with CMS. So now we have 27 core measures. And these are the core measures that have been selected, and they serve as the foundation for a lot of our work in terms of testing the HIE infrastructure that I'm going to get to in a moment, but then from our perspective at the Medical Society, continuing to talk about how do we reward physicians and providers more similarly in these areas. And I know I've flashed this measure set a couple times. It is on the MSMS website. You can find it online. I'm also going to have my email at the end of this presentation. I'd be happy to send you the list directly. So we're currently in a pilot phase that MiHIN is helping to facilitate. We have 6 physician organizations out of our 12 partners and continuing to talk to our remaining partners about how to get involved. Those 6 organizations are in varying sort of stages of that technical pilot. And then we have 5 major health plans, and we continue to grow that list. In fact, I've had several health plans come to me following this conference saying they'd like to get involved, and we certainly welcome their participation, that are going to be receiving this data from the infrastructure that we're starting to build. As of last week, most of the POs, I think actually all of the POs listed there, with maybe one exception, have established connection with MiHIN to send their common measure set. And payers have begun to send their member attribution files to do some of the matching for the routing process on the IT infrastructure. So, well, I guess I'll take a poll of the audience because I'm curious. I know that there's a number of stakeholders that attend these conferences. Who is a provider or works with provider organizations? So a few people. Who's from a health plan? About the same number. So everyone else is from some sort of vendor IT world. Is that an accurate description? FQHCs? Okay. Well, those are providers, absolutely. State Medicaid. Okay. So again, these are the 27 core measures, and this is the foundation for all the work that we're doing. Once we had those core measures, now I'm back on track in my mind. Threw me off there for a second. Once we had those core measures, we had to talk about what we're going to do with them. So we spent a lot of time over several months talking about data capture and collection of those measures. The first meeting, which I think was about 2 hours, was essentially both the health plans and the POs complaining about all the troubles and barriers that they run into trying to extract quality data from EMR systems. And so it was sort of like a therapy session for everyone. And it was good. It was good because people got to hear the frustrations on both sides, and I think that's one of the reasons the PPQC effort has been as successful as it has in a relatively short period of time, is because everyone is facing similar challenges, even though they're sometimes perceived to be on different sides of the equation. But once we got through that group therapy, we moved to a discussion on, okay, how can we start to standardize some areas of the data infrastructure to begin to actually move data in a more efficient manner. And one of the things that emerged in those discussions was that Blue Care Network had a file format that was had been widely used for maybe almost a decade. That they were one of the first people in the state in this space in the state, and the physician organization community had a lot of experience using that file format and reporting their quality performance to BCN. And in that discussion, a lot of the other payers, when we were saying, could you accept the BCN file format, they said, most of the other payers said, yeah, absolutely, because when we stood up our process, we sort of copied BCN's file format anyways. So that was sort of the short-term solution to get this infrastructure stood up. However, as it's been said repeatedly over the past 3 days of this conference, QRDA is the standard that everyone wants to move to. That's the desired future state. So, you know, as Medicaid is accepting the QRDA format, I think we're going to move pretty quickly to the QRDA for the submission of quality measures. And at the end of Dr. Tom's presentation, he showed the MiHIN legal framework. We're using that same framework for a lot of this process through the pilot, so everyone's protected and secure and feels comfortable exchanging that data. And then we solicited, you know, those physician organizations that I had shown earlier, who's going to start sending this all-payer expanded BCN file format so it can get routed to the appropriate endpoints. So I steal liberally slides from MiHIN because I think they do a great job with their visual representations of the problem. This is the problem that we're trying to solve for a lot of the physician organizations, and you see 3 payers represented on the, I guess, right-hand side of this slide. They all accept things in a slightly different file format, transport mechanism, and you have this spaghetti diagram in between. And this is just with 3 payers. You know, I have organizations that are contracting with up to 10 or more. So it's administratively it's a burden. This is where we're trying to get to, and this is, you know, an example of one physician organization. You see there the all-payer supplemental data file, which is what we changed. It's the expanded BCN format that everyone agreed to. It gets routed from one point, reported one time, and it goes through the MiHIN networks and then gets matched with the payer attribution lists and routed to the appropriate endpoint. So again, here are the participants in the pilot. We have 6 currently. They're all at varying stages. The vast majority have made the connection. Several are sending and uploading that all-patient, all-payer file already. We have payers that have sent their member attribution list to MiHIN. There has been some initial matching, and some early matches identified gaps in data, as one of the PO representatives put it, and it wasn't insignificant. We had a PO send in an all-patient file that they did not expect to have any hits from a certain health plan, and I'm going to make it anonymous just for sensitivities. They had, I think, 5,000 or so data hits, and that could be real money. That could be real money. They wouldn't have been reporting that data to the payer in any other fashion with their sort of direct data exchange, because they didn't think that they had any patients attributed to that health plan. So that's a significant early win. Continuing on the pilot activities, we're going to keep having those POs that have made the connection send in their all-patient data file. They're going to do so on a monthly basis with a full historical file based on the measurements look-back period every quarter. And the reason that they're going to do that is, again, to identify those gaps in data and what might have been missed as patients change providers, change health plans, et cetera. Just last week, we had, I believe, our 7th meeting of the pilot process, and it really focused on a discussion on standardization of gaps in care feedback from the health plans to the POs. Some of the things that were discussed were a standard file format, similar to how the POs are going to standardize in the short term on that all-payer supplemental file, and hopefully to the future QRDA. It was agreed that the health plans and reporting back their gaps in care in the short term would have a simple Excel file with a transition to QRDA as quickly as possible. And I will note, because a lot of our groups are independent, represent independent physicians, you know, even that Excel file is going to be a challenge in the short term for some people to sort of catch and digest. And the health plans, you know, they were very clear that they would love to move to QRDA as quickly as possible, but that they still have challenges. They have to send PDF files to these people, and sometimes they have to do so by fax. So there's a lot of work to be done in building up that capacity from a provider side to participate in these things. Another thing that we talked about was syncing of a health plan process timeline. You know, health plans were saying, you know, we want, you know, their supplemental data by the end of the month so we can get the gaps in care report back to them by the 15th. If you don't get it in by the end of the month, then you get kicked to the next month. The POs, on the flip side of that, we're saying, yeah, that the health plans say the 15th, but then sometimes we get letters saying, oh, you're not going to get it to the 18th or the 20th. So, you know, we're hoping that standardization of file format will, you know, sync up those timelines. And then again, you know, I think it was the Orion folks talking about liquid data and trying to move to real time. That obviously is the most desired future state. So this is just, again, some slides that I stole from MiHIN, sort of the reverse of the first spaghetti diagram. You know, you have all these health plans that have different ways to report back their gaps in care, different file formats. Some of them have you log into a portal to extract a file. Some of you have it to log into a portal to you know, close the gaps in that portal itself. And we're trying to make it more streamlined. Again, you have all of the payers on the left side sending one master file back to one point through MiHIN and routing it in reverse to the appropriate physician organization to consume and close gaps. And this is sort of the, I guess, what we call the rainbow slide. That's the desired future state. You can see on both sides, from the PO perspective and the health plan perspective, 1 point of entry, 1 point of receipt. And that's hopefully where we're going to be moving to pretty quickly, or as quickly as possible. So next steps from a medical society perspective, while and I think one of the earlier slides that I had was the study that, for those that saw Bo's presentation this morning, the study on the amount of time and money spent on administrative activities around quality reporting. While that's important, and we think that cleaning up this sort of messy spaghetti diagram process has inherent value for providers in and of itself, we also want to continue to have a conversation with the health plans about how do we harmonize incentives, specifically around those 27 core measures. You know, I made the comment on the panel discussion that every health plan thinks that they have the special sauce that's going to differentiate them and make them really the highest quality, but you know, we didn't pick these 27 core measures out of nowhere. The health plan said that these were already important to them, so why do we have to treat them differently? And we're going to be doing a survey to see if we can reveal where some deviation is amongst health plans, and then we're going to pressure them on why they deviate from their health plan colleagues. And then hopefully use that information to identify, you know, once we can harmonize those things, you know, we can inform the provider community, this is how you need to document and code to successfully close these gaps in care and get credit for the quality you're providing. And then we're going to use PPQC as a launch for some complementary efforts. One of those is that we'd like to form an EMR subcommittee. Some of this work is already happening with MiHIN. We're having some calls with some major EMR vendors. We're communicating the 27 core quality measures that the physician organization and payer community has prioritized here in Michigan. We're asking those vendors if they're ready to adopt the QRDA format, particularly for those measures in the core set. And then we're going to, as a medical society, gather that information and disseminate it out to providers and help them make more informed decisions around EMR vendor selection and adoption into their practices. And again, and I think this wraps in nicely with the PTN grant effort you saw, and I was talking with those folks about how we might coordinate some of these efforts. You know, we needed to do a lot of physician education in these areas around appropriate coding and documentation, how to do data entry into the various vendor platforms. You know, one of the things I've learned through this process is, you know, a vendor might have 10 different fields where a value can be inputted, but for reporting purposes, it's only pulling from 3 or 4 of those fields. We need to educate our providers to do that because they think they're putting it in the EMR and going to get credit for that, but they're not putting it in the sort of appropriate way for them to get credit for that performance. And then we're going to share best practices, across physician organizations, and then help the PO leaders engage their practices in these efforts. And then, just some possible others. How do we continue to build on this infrastructure, help POs with their predictive data analytics, identify partners that, from a software standpoint, that can help POs do that, risk management programs specific on the core measures, and then again, possibly forming a patient safety organization in some of these areas. So that was sort of a more detailed version of the panel discussion, but again, I think I had 25 minutes or so to run through that. So a year's worth of work that continues, and it's a tremendous effort, and again, we couldn't do it without the help of MiHIN. It's been a great collaboration, and I would just want to thank them again for their help with all of this and inviting me to present to all of you, and I'm open to take any questions. I think we have a couple minutes or so.
As part of your next steps, are you planning on reaching out to other health plans as well as POs? The reason why I'm asking is I'm with Michigan Primary Care Association, and our FQHCs work with 12 different Medicaid plans, and that is a big challenge when you have to report to every individual plan a little bit differently.
Right.
So we would be interested in talking to you.
Yep.
So I just want to know what you are doing as part of your next steps.
Yeah, absolutely. I'd be more than happy to talk to you about how you can join these efforts. I think the more voices that we have, the more successful this is going to be. We've been sort of operating on, what I'll steal the term, a coalition of the willing, right? Like we just want to, this is all a pilot activity. Those people that are willing to engage, we will certainly engage, but we're looking to grow this effort so all physician organizations can participate, and it's sort of the standard system that if a health plan wants to get supplemental clinical data, they get it through this new infrastructure that we're building in the future, relying again on the QRDA standard format. Well, we have to start with the willing. I don't have a mechanism to make force people to do it, but I'd be open to your ideas on how we achieve that.
Yeah, I want to say kudos to you guys here in Michigan. This is really terrific work, and to the Medical Society for being a leader in this, which is fantastic. I think the more kind of leadership we show as a physician community, the better solutions we'll have that meet our needs. My question is about kind of next steps, and especially around specialists. What I hear when I talk to specialty societies, which I assume are part of your medical society, they feel like this is really primary care oriented, and they feel like they're far behind and can't quite figure out how to jump on the train, and wondering what your thoughts are and how you've been working or thinking about the specialists in your state.
Yeah, I mean, it is a challenge. A lot of the work, not just from a quality reporting standpoint, but from a payment new reimbursement model standpoint has been centered on primary care, right? But if you look at the core measures, while a lot of them are sort of preventative focus, clinical screenings, I mean, there are some that we can begin to engage some conversations with specialists. And the physician organizations, I should mention, that are part of this effort and really leading this effort do represent all specialties within their network. So you know, that's a discussion we're looking to have. I don't necessarily have an answer for that yet, but certainly at the Medical Society, we represent all physicians, MD, DO, every specialty. So we do know that we need to bring the specialty community into this discussion, and we're going to help the physician organization leaders do that. I'm glad to hear there are specialists out there that are eager to do it. I think a lot of specialists, you know, are still hesitant to engage in these types of activities, but I think that goes back to most of the payment models right now. They need to see that what the return is for their specialty practice business model. So again, I think, you know, as we continue to talk about what incentives look like and alignment of incentives, we'll eventually get there.